Welcome to the Global Robotic Assisted Surgery Podcast, or GRASP for short. We release weekly podcasts featuring insights from leading surgeons and other surgical professionals. Our host for today is Professor Hitendra Patel, who is a global key opinion leader in robotic assisted surgery, telesurgery, and editor-in-chief of the World's Journal of Clinical Oncology. We hope you enjoy the GRASP podcast.
Welcome to the Global Robotic Assisted Surgery Podcast, or GRASP. I am honoured and privileged today in this episode to welcome Dr. Ben Chung from Stanford University. Welcome, Ben.
Thanks so much for having me, Hitendra. It's great to be here.
Oh, that's my absolute pleasure. Now, just before we get started, Ben, would you like to just tell us, because the audience always likes to know about our journey to get to where we've got to. So do you want to just give us a little synopsis of your journey to get to the top as you are at Stanford, Director of Robotic Surgery there?
Yeah, I'm actually scheduled to speak to some of our medical students next week or in a couple of weeks. And, and they're in the process of deciding for urology as a specialty, if you had told me at that stage of the game, second year or first year of medical school, I would have probably told you I was going to do internal medicine or something like that, something completely unsurgical. And but what happened was when I was in medical school, we had something called like a career fair or something along those lines, where people of different specialties line up on a table format. So each specialty has a table, and they kind of talk to you about their specialty. And truthfully, as I mentioned, I had really no idea what I wanted to do at that time. My father, however, he's a OBGYN. So I said, well, maybe I'll think about something more surgical in nature, who knows? But to be honest with you, and, he wouldn't have any, he would not hold this against me in any way. His lifestyle was, as you can imagine, pretty rigorous, especially when it came to the obstetrical part of it. So I kind of said, well, I'll keep it open, but as a second year, you're just doing studies, you're not really into the clinical rotations yet, so you really have no idea. When I went to the urology table thinking, okay, well, let me just hear what these people have to say, because I really don't know much about it, to be honest with you. Yeah. And the gentleman there, I think he just retired, he was in a private practice, kind of a private practice with residents, said, well, the reason I like urology is because we get all the best toys, we get all the best technical advances, we get all the best, I'm like, what does that mean? He said, well, and this is like 1996, right? So this is well before the advent of robotics or anything like that. I said, well, I get to use small ureteroscopes to do stone procedures. I get to do a TURP. I get to do endoscopic stuff, but I also get to do bigger things like an open radical prostatectomy, cystectomy, nephrectomy. I said, that's certainly alluring, right? And he said, also you get to do some medicine as well, right? You get to, it's not just a purely surgical field. There's also some medicine, non-surgical aspects to it. So I said, well, that's interesting. And my now wife at the time said, what are you doing over there? I said, oh, I'm just, okay, fine. Just, yeah, look and see and try to, feel it all out. But, as time went on, I read more about it and I thought more about it. I said, well, this is actually similar to what my father was doing in his OBGYN practice, minus the OB in some ways, right? You don't have to worry about people delivering. And, that's obviously, there's no way to really predict when and where that's going to happen. And the uncertainty of it. And the more I got into it, the more I liked it. Obviously the technical aspects, notwithstanding, which we could talk about, those were, very much in the urologist's armamentarium, but also the people, like yourself, like myself, we're kind of the same type of person, and, worldwide, not just here, not just in the UK, everywhere. And, that, you want to be around people that you like to be around. And I think that was really important. So I went into my urology residency at Leahy Clinic in the Boston area. And at the time, we recruited someone from Germany to, at that time, which is around 2003, spearhead the minimally invasive aspect, because at that time, robotics was really in its infancy. I remember actually as an intern in 1999, watching a Grand Rounds presentation on the Da Vinci robot, but it was presented from a cardiac surgical experience. The cardiac surgeons were presenting this, video on robotics, and I said, "Oh, okay, whatever, right?" I mean, this seems like a quantum leap, right? In 1999, it's like someone talking to you about an iPhone when you're still in a flip phone phase. It just doesn't really, it's not really connecting because it's so out there. But as I went through my urology residency, 2003, we recruited someone from Germany who had a lot of experience in laparoscopic prostatectomy, which, as you may remember, but if I talk to my residents now, they would have no idea, right? It was a journal urology paper like in 1999, and it was the folks from France. I think it was the Montsouris Institute, and it was hand-drawn illustrations of a laparoscopic prostatectomy. And at first we read this paper in our journal club and we said, nah, it's not going to happen, right? This can only be done by a few certain people, which is true, right? I mean, trying to do it that way was really limiting. But as I got more and more exposed to minimally invasive techniques, I realized that this was truly the future of urology, and it wasn't long before Dr. Patel and Dr. Allering and Dr. Menon all produced papers and literature and evidence, and then I said, well, this is really the way to go. And I did my fellowship with Indy Gale at Cleveland Clinic, who I'm sure you're very familiar with. He's got a lot of urologic connections within Baus and the UK. That's where it really took off. And but that was a time where 2005, 2006, there wasn't a lot of people doing it. So I came here to Stanford and was able to shepherd the progress from God forbid, the original standard system where you had to actually screw the ports in, all the way up to XI and SP. So long and short of it is that I feel very fortunate to be in a field where we value and adopt technical advances, and I think it's really for the better of the patients, for the better of for everybody, really.
Well, thank you, Ben. You mentioned your father, Ben. Interesting, OBGYN. So I mean, they were pioneering in the minimally invasive surgery world, weren't they? So was your dad involved with minimally invasive surgery? Is it genetic? Is that why you're so good?
He at the time his practice, sure, they were doing lots of laparoscopic procedures. Some of those were, and obviously hysteroscopic and all that. But while he was in this practice, he wasn't doing, say, for example, I don't think laparoscopic hysterectomy. I think those are all still done open. But perhaps because when I told him I was going to do urology, he obviously, there's a bit of a inter-specialty rivalry there. So he kind of said, why do you want to do this? And then he thought about it. He said, well, actually, to be honest with you, I almost did urology myself. But back then in the mid 60s, urology was a very, very different field than it is now. And I didn't realize that, but I know you realize that. At that time, it was a lot of TURPs. It was a lot of BPH. There wasn't a lot of prostate cancer treatment going on then. I think most of the prostate cancer treatment going on then was probably radiation, or, they weren't diagnosed till they were, advanced disease. So really surgery was out of the question. So by the time doing TURPs was not how we do TURPs now, right? There wasn't a camera. You basically had to put your face onto the eyepiece and, do your TURP, and you're just getting splashed with liquid and fluid. And he said, okay, that part didn't really appeal to him. Of course, as we on the vein of, technological advances, obviously that's, if I had told a resident now, okay, yeah, you used to do TURPs, but putting your face on the face right on the cystoscope, they would have laughed literally laughed at you. But so, no, I think there was, maybe there was some genetic underpinning but I feel that, I can dispute this with my father. I think I made the right choice compared to doing, say, something like OBGYN.
Yeah, I think you made a good choice as well. It's funny father-son combinations because my son has just gone off to medical school, and I think I put him off going. So I said, "Oh, do something else." Just because it's hard work, long hours. You have to be dedicated. You got to get out of bed in the morning early, etc. As you know. But no, he's very keen, and he does get up early, and he's he's enjoying it, actually. But anyway, Ben, back to yourself. Beyond father and son relationships, you are Director of Robotic Surgery at Stanford, and you've had an illustrious career and, in fact, training programs as well. As you mentioned in the Big Gill, and you mentioned that you're in the Boston area, the Lay Clinic's very famous clinic for training. But in terms of while you're on that journey of training to be a robotic surgeon, did you have to do any other types of research, or was it something interesting for you apart from the surgery? I mean, in terms of research?
Yeah, so, when I came to Stanford in 2006, this was very much a bench to bedside type of academic center. And unlike maybe some other places, really and it may be less true nowadays, but really your academic profile and status was forged by what kind of research you did. But back then, trying to do research was, saying, okay, I'm going to, let's say I'm at the Cleveland Clinic or Mayo Clinic or someplace like that. I have 10,000 patients in a database, and I'm going to try to, look at my outcomes for X, Y, and Z. But we didn't have access to that kind of, research. So, well, with lack of having that type of research, what can we do instead? Well, we can look at outcomes, and outcomes research at that time was just coming on. So what happened was that kind of dovetailed into me getting a master's in epidemiology, but also at the same time collaborating with some of my colleagues around the country to look at robotic adoption, actually, and outcomes. In other words, how did robotic surgeries come to be adopted? Why, when, where, how? For example, robotic prostatectomy, talked a little bit about that. Why did this happen so quickly? I mean, within a few years, this was all the talk, and everyone was trying to do a robotic prostatectomy, and that was much, much quicker a process than, say, something along the same lines. Of course, not exactly the same, like a laparoscopic cholecystectomy, right? That obviously was adopted, to a very, very high rate for obvious reasons, but that took quite a bit longer. And I think it has to do with very, very good marketing and better ease of or better methodology of disseminating information and techniques and understanding, and also, but the facility of urologists to really adopt something that really required them to completely change how they were doing things. And we found that these things were adopted in a very predictable way, starting from early adopters, and then all the way down to people who are laggards in adoption. But and we found the same with the robotic partial nephrectomy and also robotic radical nephrectomy. So, and there are various components to how these were looked at and adopted. So to a large extent, they're adopted by high volume users and centralized locations. Cost really, at least in the United States, didn't really become an issue as far as, discouraging people to adopt, for example, right? So cost was not a barrier to adoption. And, that really helped speed the adoption. But also, I think as people got more familiar with the robotic platform, then, jumping to robotic partial nephrectomy or robotic radical nephrectomy, for example, also became much more facile at doing so, and it became much easier to do so. And I think, studying these things was very interesting, within a robotic surgical context.
Ben, you mentioned cost as not being an inhibitor to adoption, but I mean, we still have the same problem right now, where robotics is now, many, many places. But how do we get it to all places? What if you're not such a high volume center? What if you don't have the big bucks? Do you have any suggestions for the listeners and the viewers, what can they do to help themselves get involved with robotics?
It's a very good question, because this is not something we're used to discussing here. I mean, no, by and large, as you know, compared to other places, getting a robot is not necessarily a source of economic angst or difficulty or a barrier, but other places I understand that it is, and I totally understand why. So I think what's happening, as we're seeing, is that Intuitive or the main companies have made some incentivization to lower prices, by offering platforms like the X versus the XI, but also there are other companies that have obviously been exploring and developing robotic platforms. They're obviously not yet approved for use here in the United States, but they are approved for use, as far as I know, in the EU and other countries like South America. So I think that these other platforms, by means of just competition, will continue to drive down the cost of doing business, especially from a robotic standpoint. But no, I understand how I have colleagues from other countries. I talk to them about limitations of resources, and sometimes that forces them to do procedures laparoscopically or open even, or have to very carefully pick and choose what instruments they use or what cases they do it on. So I think there are certainly economic considerations, which I hope as time goes on will start to diminish and allow more even access to something like a robotic platform for surgeries.
If I could be so bold as to ask you, if you take out the economic factor, if operating on a patient with a robot was the best thing you could offer that patient, do you think that's a driver for the robotic companies, because currently, there are now 9 platforms available globally. So do you think there's a way of, if robotics truly gave you better outcomes, and you can please answer that as well if you think it does or not, but do you think that's a driver for the patient-centric opportunity to give people the best outcome you can give them?
So trying to answer the question if it's absolutely best for the patient is difficult, obviously, compared to something. Well, I mean, I think there are certain situations where with very, very difficult technical surgeries, say like a very, very complicated robotic partial nephrectomy, it would be hard pressed to find someone who could do that procedure laparoscopically, for example, as well. So I think in those situations, although of course trying to prove that through some sort of research endeavor would be difficult, I don't think anyone would deny that having a robotic platform in a situation where the case is very complex having that platform is really for the advantage of the patient, rather than converting to an open procedure, for example, to do the same thing. Same goes with robotic prostatectomy. The last thing you want to do is trying to have someone who could do robotically but not laparoscopically, not well, because of the technical demands, and then end up taking double the amount of time to do the procedure. That doesn't help the patient either. But your question is really about if it could be shown that robotics is better, then what could we do to make the cost less, or what was the exact question again?
Oh, sorry. Forgive me. If in the ideal world the robotic procedure was the best for a patient, is there an argument to discuss that with the companies, or to work more closely together to give better outcomes for patients? Because ultimately, some countries can, it's the economic argument again, where countries that can afford to buy high tech like the robots, they can afford to give their patients potentially better surgery. So to get that into other countries with who are low socioeconomically gifted, what are your thoughts about, if it's not about money and it's more about patient outcomes, then how do we make that argument so that the technology companies work with us a bit better in terms of perhaps giving, let's call it developing countries, more help in using these types of technologies? Because like you said, you and I can afford them where we work, and other people can't. So is there something else we can do, do you think, based on an argument that patient outcomes are better? Although not proven, right? I get that.
Right. I think the first part of your question, certainly it would be great to, and we do, work together with these companies to try to improve specific outcomes related to urology or urologic specific procedures. But that being said, I think these companies also have an incentive to make sure that their platform is widely adopted across many specialties, general surgery, OBGYN or gynecology, head and neck surgery, thoracic, you name it. So I think, and I think to a certain extent, urology is not a major growth area for robotics anymore because, in a lot of ways we've become saturated with what we're doing. It's good that we're saturated because we're doing it at a very high quality, at a very high adoption. But compared to other specialties which are farther behind than we are, then of course, it serves them better to ensure that those other specialties become saturated in the same way as far as robotic adoption. But, I think reminding them that, we are still kind of at the cutting edge, maybe even more so than anybody else within the field. And by continuing to prove that we can make subtle improvements in the procedures to benefit patients is obviously in everyone's best interest. Now, trying to translate that to some kind of cost, how should I say it, reduction for developing countries, that's, more difficult, right? Because now we're dealing with a capitalistic entity that obviously has their eyes on profit margins and the like. So, there could be foundations to be set up, perhaps within the company, maybe external to the company, even within, a variety of philanthropic organizations and foundations to help fund these things. But, right, I mean, it's a very good question. Trying to ensure that the companies will follow through with that on their own is probably asking a bit too much.
Yeah. It was probably a philosophical question, right? Based on the capitalistic entity, as you say. So if we just move along a little bit then. So, and thank you for your excellent answers so far. If we go into where we want to be next, so you're an experienced person teaching other people, and you're involved with the cutting edge of what we're doing in the world of robotics. So when you're in the OR yourself, and let's say in the last few months, have you sat there and gone, I wish the robot had this tool? So if you had a wish list of what you would like to add to your robotic system in terms of tools, what do you reckon? What might you want next?
Yeah, so this is a question that I faced a lot, and it's like, we're so used to the way the robot currently looks and feels and operates that it's sometimes hard to think out of the box, right? So, for example, take your car, right? Now, if you're trying to imagine your car in a very, very different, way, what do I really wish my car could do? It's like, well, I guess I could say I wish it drove itself, for example, right? Which you can argue it does or doesn't at this point. I think certainly that's a goal. Whether it does it well, I mean, that could be subject to another 1 hour or longer webinar podcast to discuss, the pros and cons of that. But, so for example, what do I wish the robot could do better? Well, I think things that the envelope has been pushed with urology and other specialties with single port applications. In my opinion, does it do it well? Well, I think the single port platform was designed to optimally allow head and neck surgeons to do their thing, to do their procedures. Was it designed for us? Not really, not primarily. Does it do it well? It does it, but it doesn't. It could definitely, just like anything, be improved upon. On a variety of things, technical reasons we don't have to go into. But also, I mentioned the car, right? So it'd be great if I could push a button, this car would just go on its own, and I don't have to even lift a finger and let it go there. Well, of course, it doesn't do that just yet. Could a robot do that? Well, potentially yes, right? I mean, we're going to go into a much larger discussion about AI and the like, and AI obviously is on everyone's mind these days. Ultimately, probably not in my lifetime. That probably will be something that may be within the realm of possibility. But right now, I think trying to move the needle to a point where, we take the error out of surgery, because, as to do a surgery well takes a lot of effort, a lot of time, and a lot of experience. And, when you take residents through that, they don't have the level of experience to see what's going on and how to prevent yourself from getting to an issue. Just like my son, I have two sons, one's 18, one's 16. The 16-year-old's learning how to drive. but obviously he lacks the skills to anticipate a situation that may be unfolding right in front of his eyes that I can see, but he can't. So I think, having these types of technological advances where we could rely on either something AI related, technologically related to improve our ability to do surgery, that would obviously, that's maybe not necessarily something robotic, but the fact that the robot is the tool we're using makes something like that much more possible from a technologic standpoint. You'll ask other robotic surgeons, they say, well, I'd like to have some tactile feedback and haptic feedback. Sure, of course, we'd all want that. But, is that a game changer? I don't know about that. I think we've done a good job without that, but a game changer would be, like I said, I drove here this morning. If I pushed a button, I could get some work done at the same time that my car was driving here. That'd be great. And not to say I don't want to do the surgery, but anything we could do to make our ability to do the surgery well better, it would be a very welcome advance. And I think we're going. I think that's what's going.
No, it's a great answer. I think what you've, in all that you've just said, there are the game changer elements that you mentioned. The huge gains, but most technological revolution has been evolution. It's been little nudges, isn't it? It's been little steps. 1 + 1 becomes 4. So it kind of doesn't seem to add up, but it does. And so if you had to pick something though, Ben, in the near future, okay, let's just go to AI, because you mentioned it, and driverless cars, you mentioned them as well. So all the technology is pretty super sexy. It's all incredible. And it's all going well outside of healthcare. Is there anything you've seen? I mean, you're at Stanford, you're at Palo Alto, you're in one of the absolute brain centers in the globe for innovation. And maybe you can't tell us, maybe it's a secret, but is there anything you think or can see just coming around the corner that might be of some benefit to your patients in the world of urology?
Yeah, so I agree with the incremental steps, 1 + 1 + 1. Eventually, it's additive. Just like with ChatGPT, no one saw that coming, right? I mean, here's ChatGPT, and all of a sudden, it's opened up, huge possibilities and really improved on everyone's ability to understand what AI really is. So, I don't have, or maybe I do. I don't have behind the scenes knowledge. Maybe I do more so than everybody else.
It's tongue in cheek. I was kidding. But if we go, you're in the right place for all these incredible innovations to happen. So I just, sometimes you're just walking up a corridor and you just bump into somebody and it's like, oh wow, that's happening. Let's go back to the AI thing. I mean, are you actually using AI for anything useful at the moment?
Yeah. So one of my colleagues here, he's using AI. He's looking at he's looking at how AI could help better read prostate MRIs.
Yeah.
Right. So everyone, understands that, I mean, not AI sure is going to be applicable to a specialty like urology, but I think it's obviously much more applicable to a specialty like radiology or pathology, where you're dealing with imaging that can be digitized, segmented, and the like, and subject to a test set to validate it, or test set for learning set and then a validation set. So I do think that these types of advances are going to definitely help patients' lives, because they'll take some of the variability out of, say, prostate MRIs, for example. We were talking about urologic standpoint, or a Gleason scoring, or histologic analyses, these types of things.
Yeah.
But that's going to bleed into what we do from a specialty as well, surgically, saying, okay, well, let's examine what you did during the surgery, how long it took. You had a complication. Why did that happen? What type of complication was it? So I think all these things are going to improve patients' lives. I don't think there's any question about it.
Yeah.
Of course, we're right to be scared of it, because everyone is scared of change, but I think there's no question it'll help.
Yeah. So let's talk about, that's a very good example, radiology and AI. So we currently would plan surgeries using radiologists and the MRIs, for nerve sparing, etc., length of urethral stump, etc. Do you think we could apply AI to pre-planning surgery? Think that's something that's might be around the corner?
I can't see why not, for the same reasons, right?
Yeah.
Let's say, this is controversial. Let's say urethral length was, we knew was 100% correlated to continence, which it's not, but say, okay, well, this patient's urethral length is X, Y, and Z. So you'll either have to try to, spare more without compromising oncologic results, or just tell the patient up in advance, look, we know that in your situation, this could be an issue. Just, let's give you a little bit preemptive knowledge that you're prepared for that, or your continence could take longer to recover, or, the PIRADS 5 lesion is in this location. We'll do everything we can to cleanly excise it, but, just realize that, over our learning set, we understand that your chance of a positive margin here is X%, and you might need radiation later. So I think those things are not quite there yet, but likely to be soon.
Yeah. Okay. So Ben, thank you. Those are amazing insights already. So just a bit more lighthearted now. When you're not working and you're not with your boys, what are you doing to relax and look after yourself?
Yeah, so someone asked me that recently, and the answer is hard to come at, right? I mean, okay, I mentioned being on sabbatical this month, right? So I'm on sabbatical this month, and I mentioned this to you off the record, or off before we started this recording, because during the pandemic, because the hospital was shut down for a period of time, the university actually encouraged us to take sabbatical. And actually, for me, it was a great period of growth. And it was a period of growth because I actually realized that as we do our job, we kind of end up on this, for lack of a better analogy, a hamster wheel, right? You're running faster, and you fail to notice that if you step off the hamster wheel, there's, I don't know, a water bottle, there's wood chips, there's food, there's a light, So I got off the hamster wheel for a little bit, and I said, I'm actually not spending enough time with my family. And actually, I'm not spending enough time just trying to take care of myself, exercise, whatever. So what I decided at that point was, I needed to be much more cognizant of trying to balance every aspect of my life. Do we still do a good job of doing that? Well, probably not. For example, I remember when I'd been here maybe at Stanford for a couple of years, we had a visiting professor. I won't tell you who it was. He's still a chair of a major, university institution here, urology department. I asked him, how do you find balance in your life? And he actually had this look on his face like, oh boy, now I've been stumped, right? They're asking all these, difficult questions about, clinical management. He was able to fire them all off. I said, how do you find balance in your life? He kind of looked down to his shoes and said, I don't. He was just very honest. I don't have balance. I admit it. Right. I mean, I didn't want to put him on a spot like that. I was just looking for some advice. So
yeah.
So balance is incredibly hard to achieve. And, for all the reasons you discussed, about your son, and, explaining to him, look, if you're going to do this, you're going to have to do it, fully. This is going to, in some ways, it's going to take over your life. So I try to find ways that it doesn't, right? So that means taking time off, spending time with my family, exercising. Do I have a true hobby like, some of my friends who play golf once a month now, or once a week? No, I don't really do that. I just try to find activities that take me, away from just trying to do one thing and one thing only, which is make sure the clinical practice is solid, and try to make sure everything else is going well as well.
Okay, that's a great answer, and that's good advice for folks watching this. So, Dr. Ben Chung, it's been an absolute honor and a pleasure. Thank you for being on the Global Robotic Assisted Surgery podcast.
Really appreciate it. Thanks so much for inviting me and having me on. And it's always great to talk about, all of this, and thanks for putting a lot of this into greater focus on your insight on the topics.
Thank you for listening. I hope you enjoyed.
I did very much so. Thanks so much.
Thank you for listening to the Global Robotic Assisted Surgery Podcast, or GRASP for short. Please subscribe to be updated with all of our new podcasts coming out. If you would like to learn more about robotic assisted surgery, please go to www.roboticsurgerypodcast.com.